Hello, everyone. Thank you for joining us today. Welcome to our last Contagion Cultures webinar of the semester on Tuesday, November 16th, 2021. We'll start again in January, and we still have a bit of space in the lineup. So if you're a Queen's faculty who's interested in presenting some of your research on contagion cultures in the largest sense of the ramifications for society, then please let me know or let Warren maybe know in the School of Policy Studies. We're broadcasting today from the traditional territory of the Anishinaabe and Haudenosaunee, and Queen's University, as we know, was founded here in 1841 by the Queen. So on one hand, this marvelous university of learning and trying to create change in the world and make things better in the world is also, and was certainly also, but remains in its certain way, an imperial project. And we need to remember and learn about this history and use the present to try to alter the future and strive to make the past right, and to try to use the knowledge and research that we are creating here to really create change and move beyond, I'm going to say, just reconciliation into more equity. Contagion Cultures is a Faculty of Arts and Science and School of Policy Studies collaboration that I thought would be short-lived when I brainstormed it, and we've been here in pandemic time for a while, but I guess that helps us learn. My name is Jennifer Hosek. I'm a professor in languages, literatures, and cultures, and cross-listed with film and media and gender studies. And I am glad to have you today. Please submit questions in the Q&A that you can find in the middle of your screen, and we'll be able to share your questions with our speaker today. And it's really my pleasure to introduce Dr. Sachil Singh. Dr. Singh is an adjunct assistant professor in the Department of Sociology at Queen's University, and he's an associated faculty member with Surveillance Studies. And Surveillance Studies has been, their researchers have been presenting in Contagion Culture, so we're happy to have another one, always smart things to say. His main areas of research are in medical sociology, critical race studies, and algorithmic inequality. This has positioned him very well to research topics as varied as credit scoring in South America and healthcare in Canada. The common thread in all his work is attention to the racial outcomes of digital sorting technologies. And as someone who has her fingers in many pies, but doesn't have that hardcore stats background, I really think that we're really lucky at the university to have somebody who has a critical take and then has the number crunching ability to really back up important suspicions that humanities people have about the world. Of course, we can say that statistics can lie, but maybe he helps statistics tell the truth. Dr. Singh has published on these topics in leading journals such as Security Dialogue and Social Science and Medicine. And he has a forthcoming article in the journal Health, where he presents empirical findings on unintended racial biases in healthcare based on interviews he conducted with medical doctors in Southeast Ontario. He's at the start of a new project for which he is collaborating with medical geneticists at Queen's to examine the value of race in the development of prenatal screening tools. Dr. Singh is also, as though he didn't have, he doesn't have a moment to spare, but he's also a co-editor for the journal Big Data and Society, with particular interest in health, medicine, race, and surveillance. And his talk today is called Operationalizing Race in its use to track the impact of COVID-19. Thank you so much, Dr. Singh.
Thank you very much, Jen, for that wonderful introduction. I'm very glad to be here with you. And thank you to everybody who's shown up for this talk today. I'm just going to share my screen. Is that good, Jen? Can you see my presentation view? Thumbs up if you can, please.
Perfect.
Okay, great. Okay, so in today's talk, I want to share with you one aspect of my research within the field of medical sociology as it pertains to COVID-19. I want to focus on the collection of race data as a means to track the spread of the virus in Canada. Now, it seems to me that there are many problems with the use of race this way, ranging from it being a poor proxy to track the virus to it being problematic to measure. For example, what's the definition of each race type? What separates one race from another one? And is this always clear-cut? If people interpret self-identifying race labels as subjective, as they should, yet a researcher applies seemingly objective or assumed definitions, then what is actually being measured? Is race different to ethnicity? And if so, why do some public health units present them synonymously? Where do people of mixed backgrounds fit in? And on that question, what does it mean to be mixed? Does it mean having one parent of a different race? What if one of my great-grandparents was of a different race, yet I visually present as white? What happens then? How informed of their own lineage does somebody need to be when self-identifying for health reasons? Now, we won't answer all of those questions today, but they certainly indicate some of the complexities of measuring race. There are three main camps, as I see them, when it comes to discussions about race in healthcare. One camp maintains that race is a biological trait, so diseases can indeed be racialized. Therefore, they support the collection of race data on the basis of better understanding biological susceptibility to the virus. The Singh I've put up on the slide here definitely is not me. The second camp is the most dominant in medical practice. It argues that while race is not necessarily biological, it is a suitable substitute for genetics because it's closely enough correlated, more efficient and cost-effective than genetics research. And finally, the third camp argues that race is a social construct and not biological, that it is a social determinant of health. As such, racialized onset of a disease needs to be tracked, not because diseases are inherently racial, but because the spread of diseases has a disparate racial impact on societies. Race is viewed as a social determinant of health. So as we can see, the various camps seek to maintain the presence of race, but for their respective agenda. Critics of biological race argue that it is racist to think of a disease in such ways. Equally, critics of the social constructionist position maintain that this overlooks the biological truth of race. Herein lies my argument. Maintaining a focus on racial categories in healthcare, regardless of the camp, contributes to the enforcement of such categories and the reproduction of historical racial inequality. I argue that there is a determinism in all three views that position race as leading to likely outcomes. So to give you a bit of an outline for today's talk, First, for context, we'll briefly look at the collection of race data in Canada as a way to track the development of the pandemic. Secondly, I will share my concerns with the contested meanings of race more generally, so that race and COVID can be situated within a broader context. And third, we'll look at possible alternative methods of measuring COVID-19. I want to offer a very brief overview of what's happening in some Canadian provinces. Given time constraints, I just have a few examples for you, but I do want to highlight some questions and possible inconsistencies in what's going on with race data collection. Canadian provinces handle the issue of race differently, with some starting the collection of this data as early as the spring of 2020, while others are not supporters of collecting this data. So these inconsistencies should be considered against the backdrop that the National Advisory Committee on Immunization, NACI, recommended as early as February 2020 that racialized adults from at-risk populations should be prioritized in the second stage of the vaccination campaign. But to know that they are racialized would require race data. Data that Dr. Kwame Mackenzie of Toronto's Wellesley Institute argues is essential for good medicine. And many other doctors and scholars believe that collecting race data might improve the understanding of the social determinants of health. On the political front, NDP leader Jagmeet Singh urged the federal government in June 2020 to release data on COVID-19 infections by race on the basis that racial minorities are at higher risk. While the Public Health Agency of Canada, the PHAC, requests race data from the provinces, the agency confirmed that the data are reported, quote, selectively and inconsistently, with only half of provinces providing this data. That's according to a CBC report. Now, this is a concern for Prime Minister Trudeau, who maintains that the data need to be reported consistently for them to have any efficacy. But with few federal guidelines, calls for consistency are a long shot. It's also not known to the public which provinces do not report this data to the PHAC. So let's look briefly at a few examples from 4 provinces. Manitoba was the first province to begin a process of collecting race and ethnicity data on May the 1st, 2020. In that province, public health staff also ask a scripted question to people who test positive for COVID-19 to collect information on their race, ethnicity, and indigeneity. These are REI identifiers. A Manitoba Health report shows that these identifiers are based on census categories that I've included here. Notably, a footnote in the report clarifies that the REI identifiers are based on place of birth. But the mapping of the REI identifier with place of birth is odd because this would assume similar socioeconomic backgrounds of those from the same country or group of countries. And if this is to count as race data, then it means that place of birth equals race. So I ask myself, which would I pick? My place of birth is South Africa, which I see in the first row. So So do I select African? But the countries listed cover quite a range of social, economic, and possibly genetic spectrums. Would I be expected to select South Asian because of how I look? But my great-grandparents were indentured laborers who the British took from India to South Africa. And so both South Asian and African are part of my complicated identity that cannot be reduced to single REI identifiers. And to further complicate matters, my self-identified race in South Africa is recorded as white. So when would that be my REI identifier? My daughter's mother is from the Philippines. So how is my daughter to interact with such questions, given the complexities of her parents' backgrounds? What about Ontario? Ontario also started data collection early, but only in pockets of the province: Peel, Middlesex, London, and Toronto. The main reason that this practice was not more widespread in the province was that Chief Medical Officer at the time, Dr. David Williams, was initially against the collection of this data because he stated that he was more concerned with age and chronic conditions. However, the province did start collecting race data in June 2020, and healthcare workers are asked to follow a script when collecting the data. They read a list of 6 race categories to individuals for them to choose from and offer more options for additional categories if needed. Notably, it's not clear that the same open-ended options are available in Manitoba, which brings up the issue of consistency. Because some provinces like Quebec have expressed a reluctance to collect race data, some health equity groups have started their own initiatives by bypassing provincial health units entirely, such as Colors of COVID in Quebec. While this might contribute to calls for the widespread collection of this data, it does not ensure that it is collected consistently or with appropriate safeguards in place to manage sensitive data. In Alberta, the Chief Medical Officer of Health, Dr. Dina Hinshaw, acknowledges that systemic racism disadvantages certain populations, but the province, as far as I can tell, has still not published race data on COVID cases. Hinshaw has expressed her hesitancy to publish this data because of how the data could be used to stigmatize population groups. For this reason, it's not clear when the province started collecting this data, but it did confirm by December 2020 that the data collection had been going on for some time. In May 2020, the single largest outbreak of COVID-19 in North America occurred at the Cargill meat processing plant in Alberta. The first case was confirmed on April 6, but nearly half the workforce, that's 950 staff, tested positive just 1 month later, also leading to the spread of the virus amongst hundreds of family members. Investigative journalists exposed the working conditions at Cargill and at another plant a year later that found itself in similar waters. The main issues were workers working elbow to elbow, using change rooms with insufficient physical distancing, employers expecting asymptomatic workers to be back on the floor while waiting for COVID test outcomes, and so on. Now, the workers at Cargill are primarily Filipino. So those interested in race as a social determinant of health argue that this case highlights the extent to which the Canadian economy depends on the precarious employment of immigrants and temporary foreign workers who don't have easy, if any, access to private health insurance. Yes, many Filipinos were infected, which fuels calls for race data to make racial minorities visible. But not all Filipinos work at meat processing plants. Reducing a race to its interpreted racial tones could run the risk of racialized communities not seeking the appropriate healthcare that they need, or could even promote racism. In fact, the attention to race and ethnicity following this outbreak also contributed to xenophobia, with reports that Filipinos in Alberta were denied entry to some banks and supermarkets. So, against this backdrop, I want to shift gears and turn to the contested meanings of race. The view that race and ethnicity are objective constructs and therefore measurable has been heavily criticized, at least since the early 1970s, when the Human Genome Project published its findings in 2000 that people from all races share over 99.5% of the same genetic material, and that there are far more genetic differences within races than there are between races. Many scholars suggested that a biologically based understanding of race had finally met its end. Certainly, the literature abounds with contradictory findings. With respect to COVID-19, there is ongoing genetics research into racial disposition to the virus. As noted earlier, some suggest that biological race is empirically measurable and can help explain unequal health outcomes for marginalized persons. However, when race and genetics are merged, then dangerous prejudices are perpetuated. Consider the former president of the American College of Medical Genetics and Genomics, the ACMG, who in a conference just 7 months ago claimed that, quote, "The idea is that Black people and brown people and yellow people should all be able to see the benefits of next generation sequencing as it has evolved," end quote. Others suggest that biological race is a socially constructed phantom that both obfuscates cultural differences between groups and reinscribes biology with previously debunked biases that detract attention from the systemic and cultural factors that lead to poor health outcomes among racialized populations. To recognize the social construction of race, as health equity groups do, is to acknowledge that it is not medically scientific, objective, or inherently expressive of an individual's complex identity as a whole, but to isolate race and treat it as a window on social conditions, ironically risks reproducing the determinism that health equity advocates try to resist. That is to say, to assume someone's social circumstances are because of their race is to treat race to treat race as an objective construct. For race data to have any efficacy, it needs to be measured. To many anti-discrimination advocates, when race is not measured, it is overlooked, cast aside as if it doesn't matter. But to call for race to be measured assumes that it is indeed measurable. Unless one lives in a place like apartheid South Africa or Nazi Germany, with questionable tools to supposedly measure racial boundaries, such as a pencil test in the hair to see if it falls out, or a palette to compare skin tones, the act of self-identifying usually does not come with policed borders between each race type. Rather, the intention of self-identification is to afford individuals the agency to establish their own identities. But what this also means is that there is a plethora of understandings of racial identity, and that one's self-identified racial identity today does not prevent one from choosing another identity tomorrow. And so the task of measuring something potentially fluid in a supposedly uniform way is a challenge, if even desirable. Consider the case of Rachel Dolezal, a former US professor and activist who self-identifies as Black. But she's received a lot of criticism for this because the second image that you see here is the same person many years ago when she looked quite different. So what then is self-identification without clear definitions or measures? This example arguably shows how equity-seeking groups that are critical of Dolezal acknowledge the contested and messy nature of race, but then default to treating it as objective fact in practice. What about the South African Sandra Lang? Born to white Afrikaner parents, Sandra has looked different since birth. This is a genetic condition, but Sandra was classified by the apartheid state as Black, meaning that either her parents would have to surrender their racial privileges, or Sandra would not be able to live with them. That's Sandra, who you see on the right of the screen as an adult. To this day, she self-identifies as Black. I recently conducted a study on the framing of race and ethnicity in the commercial databases designed to provide medical practitioners with actionable information, even in the middle of a patient consultation. Medical doctors routinely access this information in these databases called point-of-care tools on an app on their phones. The most common ones are UpToDate and DynaMed. So how they work is that researchers publish medical findings, point-of-care tools perform daily automated searches of the literature, and then editorial teams package those findings into searchable data entries that doctors can access through the app. I studied DynaMed and found that it presents more than 200 labels of race and ethnicity that are associated with almost 400 medical conditions. DynaMed makes these connections with the use of automated software that searches hundreds of medical journals daily for research findings on a host of medical conditions. So, for instance, the search function could be to show everything in the literature on race and COVID. The data with the greatest correlations are then presented in the apps. But these correlations can contribute to racial stereotypes, such as sexually transmitted diseases are associated with Latino ethnicity and receptive anal sex. Vitamin D deficiency in children is associated with non-Hispanic Black or Mexican American ethnicity and high use of television, computers, or video games. What about insights on COVID? DynaMed tells us that Black adults may have higher in-hospital mortality compared to white adults due to a higher burden of comorbidities. We've likely heard stories about many ER wards around the world being so full and under resourced that doctors have had to make life and death decisions about treating the patient with the greatest chance of survival. If a point-of-care tool tells you that a white adult is more likely to survive, then that would potentially influence patient care, regardless of the individual symptoms. What about this one? Black race and living in areas of high population density, each associated with increased risk of positive testing for COVID. Each associated, which is to say that Black race is presented as, in and of itself, inherently more susceptible to COVID-19. While the data might indicate strong correlations and are presented as medically insightful, they reduce race, however defined, to offering an eye on contagion and experiences with different medical conditions. Now, when a medical doctor accesses such findings, their own biases towards race are yet another layer on top of the researcher's biases that influenced those original studies. For example, a medical doctor in an interview I conducted told me that when I was a resident, I was rotating with a school-based physician, and we were in a high school that was mostly Latino, and a girl came in with a sore throat. So I started taking her history and asking, have you been exposed to anybody sick? Does your throat hurt when you do this or that? Do you have a temperature? And at some point I said to her, have you had oral sex? And afterwards, the attending physician said to me, did you ask her that question because she was Latina? And I had to admit to myself that I wouldn't have necessarily asked that to a white teenager. And so automated prejudices in point of care tools meet medical doctors' own prejudices. When broad racial trends are identified with respect to COVID-19, then the evidence indicates that similar unintended biases could influence healthcare. In my research, I also found that none of DynaMed's almost 400 entries that mention race and ethnicity qualify the use of these terms, which further complicates the matter. Small found similar outcomes in a 2014 study of 205 research papers, all of which failed to define race, even though 2/3 of them used race to determine the risk of a particular disease. So not only is race largely used as a categorical given, but it is used in this way in the medical field without formal agreement on how these labels are to be objectively defined or interpreted. Linking self-identified race to the risk of a particular disease is concerning. For Collins, this is because masking surrogate connections between race and the social determinants of health simplifies an already contested term by using it as a window on other social, cultural, educational, and economic variables. I want to turn to some conclusions and ways forward. Racializing diseases establishes simplified screening criteria such that certain race groups may be disproportionately screened, while individuals of a different race who may actually present symptoms for a disease may slip through the cracks. On top of this, racializing diseases can reinforce discriminatory notions of racial oppression, such as anti-immigrationism, as we see with the histories of Tay-Sachs and sickle cell anemia that have discursively been described as a Jewish disease and Black disease, respectively, at least since the early 1900s. So when we sort by race, instead of by the social behaviors and social practices that lead to the spread of COVID-19, racialized people who don't conform with the expectation are unhelpfully included in the dataset. And so the question is vulnerability to COVID-19 due more to race or to social conditions that might correlate with race? I argue that it's the latter, because I think that social conditions more clearly contribute to the spread of COVID-19 than one's race, even if race is part of it. Instead of tracking race, we should be looking at factors like living in crowded, multi-generational households, people who face barriers to accessing healthcare and social services, those with underlying health conditions, those involved in essential work, including those involved in food processing, meat packing, and healthcare, those who live paycheck to paycheck without paid sick time, who might neglect COVID-19 symptoms and still go to work, employers forcing asymptomatic workers awaiting tests to resume on-site activities. Focusing on race as a social determinant of health is argued by many as helping to address an unequal playing field. Despite the best intentions, not all methods of collecting race data are equal, leading to databases of so-called race data in which race was not necessarily measured the same way. This applies both to the problematic inclusion of race data in medical tools like point-of-care tools and in the public health tracking of race, which is not shown to be consistent across Canada. There is no doubt that many people in all the categories I presented to you on the previous slide are racialized, but not all racialized people are in the same situations. This is why I've argued today that we need to shift the locus from race to social conditions as a mechanism to track COVID-19. And this will still present racialization for those who argue that race needs to be made more visible. In fact, by focusing primarily on social conditions and not race, the data will be cleaner and more inclusive of all those affected by COVID-19. I'll stop there for today. Thank you very much, everybody, for listening.
Inspiring words that we hope will come to fruition and be listened to. As we have many, many difficult years ahead of us, it seems to me, and the problems are rather pressing. So I'd like to thank you so much for your presentation, and I'm sure that everybody in the audience does as well. In fact, you have more thank yous in the Q&A and the chat, and I thank everyone for coming, and wish everyone the best for the week and the year, and be well.
Thank you very much. Bye-bye.